and talk about TSC-associated neuropsychiatric disorders. And this is being recorded for folks who couldn't make this meeting. So we have this information available. And what we're doing in the interest of time to make sure we're able to give all the presentations and get you as much information as possible is we're going to hold question and answers till the end. So after each presentation, if you do have a question, maybe just put it in the chat would be the most efficient, and then we'll go through the questions at the end. We are really excited. Joining us today are many people from the Herscot Center family, folks with individuals in the families that we have known many for many years. But we also have several families that we haven't yet had the opportunity to meet. So I'd like to really start by thanking the folks working with us at the Herscot Center, and not only for the effort put into this virtual meeting, but for the care they provide every day to the individuals and families with TSC that we take care of. So I'd like to briefly introduce the folks who are here for the meeting today. First is Jan Paolini, who has been a nurse for the Herscot Center for 20 years, and many of you know her well. Erin Fonseca, our other nurse, couldn't be with us today, but you'll be hearing from her later, talking about one of our ongoing trials. Also with us today is Lee Horn-Mebel, the social worker for the Herscot Center. And as I'll tell you briefly soon, the social worker has been a key component of the Herscot Center since its beginning, and that has been Lee. And Emma Barrow is also joining us, is also another social worker who works with us with our Herscot Center patients as well as pediatric epilepsy patients. Also, I'd like to introduce you to Dr. Wing Zong, who is our dietitian. As many of you know, we have used diet in the treatment of refractory or tough-to-treat seizures in individuals with TS for some time, and we're very excited now to consider using diet in approach to management and treatment of aspects of TAND. And then many of you will be happy to meet virtually Don Budgell, who is the coordinator for the Herscot Center and spends an incredible amount of time making sure when people come to see us that all the visits, all the testing, everything happens. And finally, Robin Bluestein, who is the program manager for the Herscot Center, who really helps the operations run, including this visit today. So again, I'd like to welcome you all to this. And I thought since some of you are new to us, I'd start by giving a history of the Herscot Center, which is timely. We're celebrating our 20th anniversary of the Herscot Center. And 2005 was the year of the dedication. So next year we'll be celebrating the 20th anniversary of the dedication of the Herscot Center. And kind of to tell you how it all started, and Carol and I both like to tell this story, but Carol Herscot and I were on the board of the then National Tuberous Sclerosis Association, now the TSC Alliance. And at the board meetings, at the end of the day of board meetings, many of us would go to the bar to relax and talk and chill. And Carol and I ended up sitting next to each other one night at the bar. And we started a conversation of our dream. Me as a healthcare provider who had decided to dedicate the majority of my career to TSC. And more importantly, Carol as a mother of an adult with TSC, who had traveled the TSC journey from when her son was young, no internet, very little knowledge about TSC, no MRI scans, but a journey of nonstop seizures, behavioral difficulties, other aspects of TS. And both of our shared passion and dream of building a comprehensive center to provide care to children and adults with TSC throughout their lifetime. So again, next year will be the 20th anniversary of the Herscot Center dedication. And this has all really been possible through the incredible generous support and partnership with both Jim and Carol Herscot. Over the past 20 years, we have seen over 800 individuals with TS, and the patients we currently follow range in age from infancy to 93 years of age. With time, the program has really dramatically grown, and we now have 46 specialists and are able to meet the needs of any child or adult living with TSC. Throughout the journey of the Herscot Center, we've always had a strong clinical focus on the mental health aspects of TS. When I was at Children's and starting a TSC program for kids with TSC, I noticed the behavioral difficulties, but it was really after moving to the MGH and meeting and talking with adults living with TS that I really got it. How significant the anxiety, the OCD, the other aspects of what we now call TAND or TSC-associated neuropsychiatric disorders impact the lives of individuals living with TSC, and not only those individuals, but the lives of their family. And from the start, and kind of at Carol's recommendation, at the start of the Herscot Center, we have had a dedicated psychiatrist, dedicated social worker, and a dedicated neuropsychologist helping address those aspects of TSC for individuals and families living with it. In addition to our clinical care focusing on the mental health aspects of TSC, we've also had a strong focus trying to better characterize, understand, and treat the mental health aspects of TSC. Again, now with the acronym TAND, or TSC-associated neuropsychiatric disorders. Over the years, we initially looked trying to better understand the mental health issues in adults with TSC. We've also spent a lot of time looking at epilepsy and TSC, especially since I'm an epileptologist. But not only epilepsy, but the relationship of the epilepsy to autism and cognitive impairment in TS. We also have looked at sleep disorders, which are known to occur in both children and adults with TS. Years ago, we did a study looking at sleep disorders in children. And currently, with Jan's help and our research coordinators, we're looking at trying to better characterize the sleep issues that adults with TSC face. Prior to Dr. Doyle, who I'll introduce you to today, our current Herscot Center psychiatrist, our prior psychiatrist, Larry Selter, while with us, saw over 200 children and adults with TSC. So a large population of people living with TSC with significant TAND or mental health issues. Currently, we're trying to go through his experience, trying to learn what diagnoses he gave individuals, what treatments he found effective, and also, could we understand anything about the relationship to genotype? Or is there any aspect of having a TSC1 or TSC2 mutation that affects the mental health issues that individuals have? So today, we hope to give you an overview, both of aspects of TAND, TSC-associated neuropsychiatric disorders, as well as update you on some of our current efforts to better understand and treat this aspect of TSC. So again, we're wicked excited to have you all with us today. And now I'd like to first introduce you to Dr. Rob Doyle, who has worked with us for the past 2 years as a psychiatrist at the Herscot Center for TSC. Rob has a several-decade experience in psychiatry, both taking care of children and adults at the MGH and other facilities, and has extensive experience in helping children and adults with various psychiatric conditions, including anxiety, depression, and also has an expertise in individuals with autism and other developmental disorders. So Rob, we're really excited to have you here. And Rob is actually on call today and has 70 patients to see. So in order to help make this most efficient, Rob pre-recorded his talk, but will be available at the end for question and answers. So Rob, thank you very much for participating today, and thank you very much for the role you play in the Herscot Center. We really appreciate it.
It's a real honor. Thank you, Elizabeth.
Today, I'm going to talk about the interface of tuberous sclerosis complex and psychiatry. And I want to make sure that you understand this is not all in your head. Even though I did a fellowship in psychosomatic medicine, this is true psychiatric problems that people with TSC suffer with. And it is, my goal to help identify those comorbid conditions that can really provide an extra burden of the already tremendous strain that a person has as they're dealing with their tuberous sclerosis complex. First, you may have heard this term before, TAND, T-A-N-D. It's an acronym for tuberous sclerosis complex associated neuropsychiatric disorders. And these can include disorders, almost any disorder in psychiatry, but the ones I see the most at the Herscot Center are anxiety disorders, depression, ADHD, and autism, as well as some intellectual disabilities. There are a number of behavioral problems that may or may not relate to the psychiatric condition or ADHD or autism, but may be separate on their own. And there are a number of neuropsychiatric deficits that ride along with the tuberous sclerosis symptoms. We also must keep in mind that these can cause problems in school and even in the older person with tuberous sclerosis complex in their jobs and employment. The TANDs, tuberous sclerosis associated neuropsychiatric disorders, are often associated with the lesions, whether it's a glioneuroma, hamartoma, periventricular giant cell astrocytoma, or some abnormalities in the cerebral white matter. All of these space-occupying lesions can be affecting parts of the brain, leading to the neurological and or psychiatric symptoms that go along with tuberous sclerosis complex. Some common conditions in tuberous sclerosis complex, well, we'll start with the anxiety disorders, and I'll go through these individually to let you know what I'm talking about as a psychiatrist when I mention something like generalized anxiety disorder or social anxiety disorder, PTSD. Many of you know of that because that's in the common lingo of our culture, especially in the type of world we live in today. But other things such as panic attacks, specific phobias, social phobias, and other anxiety disorders not otherwise specified, or problems that I encounter with the patients at the Herscot Center on a daily basis when I'm in clinic. Start with generalized anxiety disorder. Well, to have generalized anxiety disorder, you have to have symptoms present for at least 6 months. And these symptoms include things such as problems with concentration, irritability, feeling on edge, muscle tension, fatigue, problems with sleep. You need at least 3 of these symptoms going on for about 6 months or more. And we have to make sure that this is not due to the effects of a medical illness. So this is a little bit difficult to sort out for the layperson, but it's, for instance, if it's fatigue, that's a common symptom of, say, hypothyroidism. So that's a symptom of hypothyroidism. Muscle tension is not a symptom of tuberous sclerosis. So that would qualify as allowing this to be made as a diagnosis. Problems with concentration are not specified in the diagnosis of tuberous sclerosis complex, but we know that they do occur, and they occur sometimes because of an overlying anxiety disorder. So this is where we are with the diagnosis of generalized anxiety disorder. It is something that emerges due to being in a state of heightened anxiety, especially if you have a medical condition such as tuberous sclerosis complex. Many of my patients at the Herscot Center talk about, a constant worry. Am I going to get another lesion? Maybe on my kidney? Will it affect me in a way that I have high blood pressure? Or will it be on my brain someplace or on a nerve ending where it's going to cause seizure disorder? And I'll have to either get back on seizure medicine or increase my dose with the subsequent side effects that entails. So there are many reasons for a person with TSC to worry a lot. And when I used to see Dr. Grebelink before he retired, he was my dermatologist ever since I moved to Boston. And we one time had a chat after one of my regular checkups, talking about just how impairing this is. It's almost like cancer because you never know, is the cancer going to progress or is it going to metastasize? And TSC is similar to that because these lesions of various types can arise any place in the body almost and cause problems, whether they are physical, psychological, or other sorts of emotional problems. I remember talking to Dr. Siegel, who replaced Dr. Grebelink, just about how it must be, from the patient's point of view, for the dermatologic lesions, especially if they're more profound how that can affect their self-esteem. We'll talk a little bit about that more when I move to talking about mood disorders such as depression. But for now, to recap, generalized anxiety disorder is a overwhelming, impairing level of anxiety that lasts for at least 6 months. Will have 3 of the following symptoms: problems with concentration, irritability, feeling on edge, muscle tension, fatigue, or insomnia. And we can't explain it by the core medical condition. And that would be the case here with TSC. Social phobia. Well, the social phobia is a fear of one or more social performance situations in which the person is exposed to unfamiliar people or the possible scrutiny by others. Social phobia is very common these days, especially with the social media. Everybody has to be an influencer, and just this past weekend, for example, last weekend I was getting certified in hair transplant surgery, and it was talked about how these young people are losing their hair at an early age, and it's so impairing to them because they have to have such a presence, physical presence on social media. And the same thing can occur with people with tuberous sclerosis complex, with the various types of tumors, from Sjogren patches to the angiofibromas. All these can lead to their personal self-esteem failing. And this is why we're so lucky to have Dr. Siegel and have all those years of experience in which Dr. Grublink brought to the Herscot Center and treating and doing surgeries to help affect the cosmetic presentations of our patients with TSC. Social phobia also has to last at least 6 months to get the diagnosis, but even if it's going on for 4 months and you can't make the diagnosis, there are things we can do to treat it. And I'm not one that was going to wait all 6 months before I try to intervene. In fact, if we intervene early, we might be able to have less invasive or intrusive types of treatment. It may be easier to intervene earlier than waiting the full 6 months. And again, as most of these psychiatric conditions, you can't explain it by the core symptoms of a medical disorder. Panic attacks. Panic attacks can occur for a lot of reasons, but they usually seem to occur for no reason. That, by definition, is the way a panic attack is. Now, if you're worried about the test you didn't study for, and you have all these symptoms of panic, racing heart, sweating, you can't catch your breath because you're just overwhelmed by the fear that you're going to flunk a test, that's more of an anxiety attack. Panic attack used to be required that at least some of these attacks occur without provocation. It's not a reason for panic. It's coming out of the blue. And these people often wind up in the emergency room thinking they're having a heart attack. I mean, it's really, really intense. Profuse sweating, the heart feels like it's pounding out of your chest. There may be some nausea, dizziness, lightheadedness, hot or cold flashes can go on, chest pain. You really feel like you're having a heart attack. And there's numbness and tingling. Maybe I'm having a stroke. Who knows what's going on? But there's this sense of loss of control, or like you're about to die. Is that bad? It feels like you're about to die, many people say. And that can happen, especially when people start to get worked up about all these, what's the next variation on my TSC that's going to come about? Am I going to have another seizure? And this chronic worrying all the time tilts them into having a panic. Or panic attacks are often associated with what's called agoraphobia. In Greek, agora means the marketplace, and phobia means fear, fear of the marketplace. Well, agoraphobia, today we talk about people who are kind of become recluses. They don't want to leave home. And back in the day, you would leave home to go to the market, and people would have a panic attack in the market, and they think that the market caused the panic attack. But it's actually coming on out of the blue. It just happened that you were at the market when it happened. So the panic attacks can occur, and people will start to feel like maybe I shouldn't go to the market, maybe I shouldn't go to the store, maybe I shouldn't go to the movie because I might have a seizure, and then that will be dangerous. It might be, very embarrassing. So their world starts to shrink, and they don't want to leave home or do things as much as they used to in this fear of panic or even a seizure or something like that happening. Specific phobias, these are marked fear of an object or a situation. The fear is out of proportion to the danger, and it causes significant distress or impairment. All psychiatric illnesses have to cause significant distress or impairment. Now, the time frames that they have to be present change. For depression, as we're going to see, it only has to last 2 weeks. But you have symptoms for at least a month to get a diagnosis of post-traumatic stress disorder, and 6 months if we're talking about generalized anxiety disorder or social phobia, social anxiety disorder. And the fear is always triggered by some object or situation. And as I was explaining with the panic attacks, could be that, the situation is that you're afraid that you might have a seizure while you're driving, or while you're at church or a wedding or something, so you choose to avoid the situation. And these symptoms have to last for 6 months, and they can't be due to another mental disorder, in this case, such as schizophrenia. Think about paranoia. A paranoid schizophrenic person will not want to go to places because they feel like people or the CIA or the FBI are after them. So treatment caveats. First, SSRI medications, selective serotonin reuptake inhibitors. You don't have to memorize that for the test. It's not going to be on the test, so don't worry about that. But these are drugs like Prozac and Zoloft, Lexapro, Celexa. You may have heard of some of these. They are very effective, but we have to be careful when we're using it in patients with TSC, because many of them are seizure medicines, and the enzymes that metabolize those drugs that are used for epilepsy and seizure disorders can be tied up, and or these antidepressants can tie those enzymes in the liver up, so that the levels of the anti-epileptic drugs either get too high or too low. So one of the things I think is the most important thing I do at the Herscot Center is, make sure that the medicines I'm prescribing for a psychiatric disorder are not interfering with the seizure disorder. I always prioritize the seizure disorder and make sure that I'm not going to be affecting that. So always in my book, this is the way I practice. The seizure disorder comes first, and I'll work around, even if I have to use drugs that may not be as effective, but combining them with psychotherapy with Emma or Lehorn Mebel, or someone out in the community that specializes in CBT treatment, can actually get us to our goal without affecting the good seizure control that Dr. Teal and other neurologists have worked so hard to achieve. Benzodiazepines actually were very effective in treating anxiety disorders, almost any anxiety disorder. The problem is that they can become addictive. You can develop tolerance to them, and many people need these type of medicines for rescue seizure treatment. So their seizure rescue is a benzodiazepine, and if the person's on benzos long term to treat some anxiety disorder, perhaps it won't be working as effectively if they need it for a rescue medication. So I try to avoid using benzodiazepines if I can in treating anxiety disorders in this population. And as I mentioned, there are a number of forms of psychotherapy and behavioral interventions that can help with anxiety disorders. And some of these have been shown to work as well as the medications. In fact, even on PET scans, the most sophisticated neuroimaging we have, we can show changes that are almost indistinguishable whether they're doing CBT therapy versus medication therapy for a particular anxiety disorder. To me, I think that's Nobel Prize winning material, although those people that have done those studies never won the Nobel Prize. If I were in the committee, I'd give them one. So to let you know that there are very effective psychotherapy interventions. And when we combine the psychotherapy with medications, that often is the best outcome. And it can lower the amount of medicine we need. And think about it, that can lower the interactions with other medicines being used to treat seizures or renal conditions or hypertension that go along with TSC. Now, major depression, I've hinted at this a good bit when we were talking about anxiety, but yeah, I often think about certain anxiety disorders. I mean, some of the symptoms of major depression are the same as generalized anxiety disorder. There's problems with sleep, there's problems with concentration that could be possible, problems with energy, but for major depression, as I said, symptoms have to be present for at least 2 weeks consecutively. So most days, most of the day for 2 weeks, you're feeling sad, down, or depressed. Or in children, it could be irritability. That substitutes for sad, down, depressed feelings, because children don't know what it is to feel blue or down, but parents can see that they're very irritable, and this is not their regular state. So if you're having that for at least 2 weeks, and it has to be the depressed mood or anhedonia. Anhedonia is another Greek word, lack of pleasure. So anhedonia presents as the lack of enjoyment of things that typically are enjoyable, or a lack of motivation to do things that are enjoyable. So depression either has to have the depressed mood or the anhedonia, plus 4 or more of the following symptoms. And I just listed a few of them before. It's the problems with sleep, energy, concentration, but it goes beyond that. Other symptoms of depression could include things like weight loss or weight gain. An atypical depression person will crave carbohydrates. They typically put on weight. And instead of insomnia in the atypical depression, they tend to sleep too much. So they're sleeping a lot, but they're still tired. There can be agitation or psychomotor agitation or retardation. So this restlessness or this just sluggishness that goes with depression. We often think of the sluggishness, but there can be this kind of restlessness associated with it as well. And low self-esteem or excessive guilt, blaming yourself for things that are not your fault, sort of like we were talking about in PTSD, as I mentioned, the veteran of combat who, feels it was his fault that his buddies got blown up. That had nothing to do. He had no control over where the shrapnel was going, but he blames himself. And this is what people with depression do. Something goes wrong, it must be their fault. This excessive guilt or low self-esteem. Everybody is smarter than me. Everybody's better looking. Everybody has a better life than me. Just very low self-esteem. And lastly, thoughts of death or suicide. Homicide can also fit into the depression category as well. Now, that's major depression. There's the symptoms of major depression have to cause significant distress or impairment. As I said, that's just given for any psychiatric illness, and it's not due to a medical condition. The common masquerader is hypothyroidism, looks a lot like depression, but there are a number of other medical conditions that can mimic depression, or substance use. So people who are, on downers, or maybe you're drinking too much, they can look depressed. And it's not better accounted for by another medical condition or psychotic disorder, another psychiatric or psychotic disorder. There's people who are early stages of schizophrenia. They have this, the four A's, okay, abulia, anhedonia, and lack of pleasure, lack of energy. Their cognition is slowed. So, or major depression, you can't have any manic or hypomanic episodes going along with it. Otherwise, we now call that bipolar disorder, if those manic or hypomanic episodes last long enough and have enough symptoms to be qualified for that. The medications that I mentioned to you about treating the anxiety disorders, the selective serotonin reuptake inhibitors, were actually called antidepressants because they first went to market as antidepressants. Why? Well, it's an economic reason. To get a drug approved, it has to treat a certain condition. Now, there are more people in the world with anxiety disorders, but there are specific anxiety disorders. So to test it, you have to test the drug on generalized anxiety disorder. Then if it works there, sometimes they go after seeing if it get approved for OCD, obsessive compulsive disorder, or social phobia. But when you start to take each of those studies, they all are going to cost the same, but there are not as many people with generalized anxiety disorder as there are with major depression. There are not as many people with social phobia as there are with major depression. There are not as many people with PTSD as there are with major depression. But if you added up all those anxiety disorders, there's far more people with that conglomeration of anxiety disorders in the world than major depression. But major depression is only one disorder. So when you prove it for there, you catch a large population of people who are going to respond to that treatment. And so that's why they got the approval as antidepressants. There is a trend trying to figure out different ways of naming these things, because a person will say, well, look, doctor, you just told me I have anxiety. Why are you putting me on an antidepressant? I'm not depressed. Well, the fact is that these medicines work for various things. Even a drug like Prozac works for premenstrual dysphoric disorder. It has approval for that. But it's an antidepressant. It's a very good anti-anxiety medication as well. There's another class of drugs called SNRIs, or selective norepinephrine reuptake inhibitors, serotonin norepinephrine reuptake inhibitors. And they're good. They're second-line agents for depression. They may not work as well for anxiety disorders, but they also have other uses. For instance, involved is helpful for fibromyalgia, and may have some role in treating certain persons with TSC and chronic pain syndromes. Wellbutrin is approved for depression, but it can lower seizure threshold in higher doses, so it has to be used with some caution. However, it can be very helpful, especially the depression is more one of motivation, low energy, and poor concentration. That can be a very good medication. Sometimes we add it to the SSRI medication and make a customized SNRI with a little bit of dopamine action. It's also added, or to augment the antidepressant treatment when the SSRI, the Prozac, Zoloft, Lexapro drug by itself is not working. Adding a little Wellbutrin can help. But even for some people, even more importantly, if they develop sexual dysfunction on the SSRI, which is one of the side effects of SSRIs. They're very well tolerated and safe to use, but that's one that tends to maybe cause a little more depression than treated. So if there's something we can use to help with that, the Wellbutrin does help. And the other important part of why Wellbutrin can be helpful is that there's a number of studies showing now that with depression, as we were talking about problems with sleep, energy, appetite, those symptoms of depression, you want to get them all treated. And many people say, oh, great, now they're sleeping well, now their energy's back to normal, they're eating well, concentration's back to normal. So things are done, but not really. If the patient's still feeling like they're not that motivated, or they're not enjoying life as well as they should, the chocolate doesn't taste as good as it used to taste, Doc. Well, that tells me that I haven't really finished my job, because anhedonia, which has to be present, one of the symptoms that have to be present to have depression, is still there. One of the major symptoms is still there. And anhedonia is caused by decreased dopamine in synapses in your brain. So what Wellbutrin does is help increase dopamine, and that makes a person feel, the pleasure again in taking a bike ride or having a nice meal. Things start to be enjoyed again. So I really stress that this is very important in treating depression, is to get the anhedonia under control, not just focus on the neurovegetative symptoms, we call them, of sleep, energy, appetite, concentration, but focus too on the anhedonic parts of the depression, which are very impairing. We have to also be careful that antidepressants can make people manic. It doesn't cause bipolar disorder, but it can make you manic because they are antidepressants. They get you out of depression, but they may keep working and bring you to the level of what we call mania, where your energy is too high. You don't feel like you need sleep. You're talking too fast. You're talking too much. You're making, your mind's going a mile a minute. You're making poor decisions, taking risky behaviors. You might even feel hypersexual. And that can even, if it keeps going, could even become psychotic. So we have to be careful about that with antidepressants. But, with good follow-up, that rarely happens. There's another thing in young adults, in children, adolescents, they seem to increase the risk for suicidal behaviors. Now, suicidal behaviors are symptoms of depression, but there may be a little increase in the risk of that while on these type of medicines. So in younger adults, children, adolescents, we need to be more careful in our follow-up. And lastly, there's a term called akathisia. And again, I'm going to give you a little Greek lesson here. Akathisia means inability to sit down. And literally, in the middle of a conversation, a person will get up and feel like they have to pace around. I've never had akathisia, but I imagine it's like drinking about 3 pots of Starbucks coffee, or one of those big Dunkin' Donut things that comes in the cardboard container where you bring it to the office for the whole group to drink your coffee from. So that can be very distressing, but it will go away if you reduce the dose or hold the medication for a little bit and, start it back at a lower dose. Let's talk a little bit about autism. Now, autism are persistent deficits in social communication. This social communication thing is the big core symptom of autism, and impaired interactions, interaction deficits, and social and emotional reciprocity. Well, that's a lot of big words, so let me break it down for you. These deficits can occur in nonverbal communication, like how a person smiles when they're saying something a little provocative. They're joking, they don't really mean it, but a person with autism won't be able to recognize that the smile is like giving a cue that this is not to be taken literally. And then deficits in developing, maintaining, and understanding relationships. They just don't get it when it comes to how people interact. But some of these things can be learned, and this is why we have what's called applied behavioral analysis and other forms of psychotherapeutic treatments. So the A criteria were these social communication problems. The B criteria for autism, you have to have 2 or more in this category, and they would be restricted, repetitive patterns of behavior, interest, or activities. So the stereotypic or repetitive movements, usually the rhythmic kind of movements, flapping, rocking, playing with an object in a rhythmic way, or even kind of repetitive speech can fit into a stereotypic behavior. You may hear a person with autism reciting lines from a movie or from a cartoon with a very odd prosody in the way they're saying it, almost as if the cartoon character was saying it. There can be some inflexible sameness or routines or rituals. Things have to be done a certain way. And when things aren't, these individuals start to have a lot of distress in their life. And you can see this happening just a couple of days ago in clinic. The parent moved to a different home. And so when this adult patient came home to visit the dad, who was in a different apartment, he used to like to stay as long as he could, but this apartment wasn't the original home that he grew up in. So after about 3 hours, he is ready to go back to the group home, which is more familiar to him. So that was a clear indication of this B criteria for autism. They're highly restricted interests or abnormal intensity. So these are the adolescents, early adult men who are still interested in Pokemon and still are stuck on things that most guys gave up many years ago because it just wasn't developmentally appropriate. And then there's unusual sensitivity to or interest in sensory input in the environment. So there's certain sounds or textures or feelings that they like, or they're really aversive to. It can go either way. Autism. Some of the treatment caveats. Now, there are only 2 medications approved for treating persons with autism, and they don't treat the core symptom of autism. They treat disruptive and self-injurious behaviors in children and adolescents with autism. Now, they are used in adults off-label, but they were only tested in children. And these 2 medications are aripiprazole and risperidone. Abilify, aripiprazole, and risperidone or risperidone. And they are very effective. They can help with head banging and other self-injurious behaviors or disruptive behaviors, but they don't treat those core symptoms of autism that we just talked about. However, sometimes it is really treating it, because if it's a stereotypic head banging and that's being reduced, then yeah, we are treating a symptom of autism. But in the package insert, it's talking about these symptoms that are not necessarily core symptoms. And it can be any sort of thing, that these do work. The risperidone has a little more side effects than the aripiprazole, but they both have a number of side effects. And those side effects can include lowering the seizure threshold, metabolic syndrome, cardiac conduction problems, movement disorders, whether it's some of the movement disorders can be easily treated with Benadryl or something like Benadryl. And they'll go away. You can be on the medicine for 30 years. And if they discover some treatment and you don't need Abilify anymore, you can come off of it and come off the Benadryl. You're not going to have a permanent, likely not going to have a permanent movement disorder. But there are some that used to be thought to be permanent, and those would be the tardive dyskinesias, because it would be a kind of or a shoulder twitch like that, and funny mouth movement. It looks like an older person whose dentures don't fit right. I can say that because I used to see that in people coming in to get their dentures redone, and they were always kind of doing the funny mouth movements with that. Well, now there are some medications, and you may see advertisements for them on TV these days to help with these medication-induced tardive dyskinesia movements. ADHD, this is where I spent a lot of my early career doing research, and many of the medications you see on the market today, I saw most, if not many, if not most of the patients in the preclinical trials for these medications. And ADHD, it's used to be called ADD and ADHD. Now, we don't use the term ADD anymore. We call it all ADHD. And there's ADHD inattentive type. And for inattentive type, you have to have 6 or more of the following symptoms. Those would be difficulty sustaining attention, losing things, being easily distracted, difficulty following instructions, not listening, procrastinating, difficulty organizing, making careless errors, being forgetful. 6 of any of these or more will qualify for an inattentive diagnosis. Now, the symptoms have to cause problems in 2 or more settings, and they have to be present before the age of 7 to be called ADHD. And so if you have 6 inattentive symptoms, you got ADHD inattentive type. What they were trying to do is let people know that ADHD inattentive type and ADHD hyperactive impulsive type are all the same thing. It's like a cold with a sore throat, a runny nose, and a cough. If you just have the cough and the runny nose, you still have a cold, right? Same thing with the ADHD. If you just have inattention, you still have ADHD. If you just have hyperactivity, impulsivity, and I'll move to the next slide, the hyperactive impulsive symptoms would be things like difficulty staying in your seat, fidgeting, squirming in your seat, difficulty playing quietly, making a lot of noise in quiet activities, talking too much, interrupting, blurting out answers before the question's completed, having trouble waiting your turn, being on the go, feeling driven by a motor, hyperactive, or feeling restless on the inside of yourself. These, if you have 6 of those, it would be called ADHD hyperactive impulsive type. Now, if you have at least 6 of the inattentive type and 6 of the hyperactive impulsive types, then you qualify for a diagnosis of ADHD combined type. And there's even one called ADHD unspecified, where maybe you only have 5 symptoms, but it's causing a lot of impairment. You have 5 inattentive symptoms and you're about to get fired from work. Well, we have this term ADHD unspecified, which will allow prescribing medication because the impairment is significant. I just mentioned that, so we move on. The treatment caveats about ADHD is that stimulants are the gold standard. They work the best of almost any medicines we have in psychiatry. However, they will lower the seizure threshold. They also can increase anxiety. And as we mentioned, anxiety is a big deal for a lot of people with TSC, Tuberous Sclerosis complex. Also, they're excreted through the kidneys, and we know that the lesions often occur in the kidneys, so we have to be careful sometimes with stimulants, since they're going to be excreted through the kidneys. The other thing about the stimulants is there are other side effects that can be important in children, especially. They can reduce growth in height by 2 to 3 centimeters. And they cut the appetite. And this can be a problem in a boy or a child, even girl who's at growth spurts and they're not eating very much. And so they're not getting the building blocks they need to grow, healthy. Typically in adults is not a problem because we have an overweight adult population. And at first they were thought to be weight control drugs. In fact, Adderall used to be called Obitrol in the 1970s. Obitrol, like obesity control. That was the trade name, so that doctors knew that it was an obesity drug, Obitrol. And it's no longer marketed for weight control in adults because typically, unless you change your lifestyle, the weight will come back. You'll get used to the stimulant and you'll need more and more. So they're not used for that. They're predominantly used now for conditions such as narcolepsy, excessive daytime sleepiness in some cases, and they are approved for ADHD. There's a medication that is very well tolerated in tuberous sclerosis with seizures. It's called atomoxetine because it doesn't interact very much with the other seizure medications. And this medication was discovered here at Mass General. It was originally thought to be an antidepressant, and the group I worked in saw one of the doctors saw some data on it that it was very safe in adults with cardiac conditions because they had studied it on 1,300 adults. But they were also studying another drug you may have heard about that tended to work a little better than this one for depression. It was called Prozac. Prozac became a blockbuster drug. This one sat in a closet at Eli Lilly until we approached the company and said, it might be interesting to do a study for ADHD. And they go, well, this is what we got left. You can have it. Do what you want. We're not making any more. Well, they decided to make more when we showed that it did work for ADHD. It became the first non-stimulant medication to be approved, and non-stimulants can be abused. They can become addicted. People use them to party, but atomoxetine is not addictive. It's not habit forming, and it actually has another advantage. Stimulants can only work during the day. They have to wash out. Otherwise, you won't be sleeping at night, or you won't be sleeping very well. Atomoxetine can work around the clock. It can work 24/7. So you wake up in the morning with medication on board, and it can be combined with a stimulant so that even though it may not be as effective as a stimulant, you wake up and at the end of your day, as the stimulant's wearing off, you still have coverage. Similarly, there are the alpha agonists. These medications were first used, clonidine particularly was and still is used as a hypertension medicine, a high blood pressure medicine. But it, in addition to lowering the blood pressure, it can calm people. We use it to help people detox from opioids, and substance abusers sometimes can use it for anxiety disorders. But it is approved in a long-acting form for ADHD. It can be used with the stimulants. And again, these medications, the clonidine you'd have to take twice a day, but you still can get full 24/7 coverage around the clock. There's another one called guanfacine, long-acting guanfacine, and it only has to be taken once a day, and it gives you the full coverage as atomoxetine does 24/7. So these drugs can be combined. And people with tuberous sclerosis, we see ADHD quite a bit, just like I was mentioning, the autism. And in conclusion, we come back to our tuberous sclerosis presenting with many comorbid psychiatric and neurologic conditions. The TANDs is a thing. TANDs is a thing. And anxiety, depression, autism, ADHD, we talked about all these, but there are other things that can be associated and cause problems for people with TSC. Psychiatric medications can complicate the treatment of other conditions associated with TSC, such as epilepsy in particular. And those interactions between the drugs we use in psychiatry and the ones that are used for seizure control can be significant and really tilt the health and safety of the individual if we are not careful with that. And clinicians must pay attention to the patient's complaints as well as their family members' observations. So there are going to be many patients we see that can't really express themselves the way they want to, but those family members, whether it's parents or siblings or someone else involved in their care, that information is as important as what the patients tell you, because sometimes they can't tell you the full picture, or they're not even aware that it's a problem, but it's affecting everyone around them. So please make sure you're listening not only to the patient, which is very important, but also to the family members who can provide very good insights to the patient's problems and provide the clinician with an opportunity to give better care.
So Rob, I'd like to thank you. I think your extensive experience in treating all of these different disorders in psychiatry and mental health has really been very impactful for us as we approach helping manage these different aspects of TAND for individuals living with TSC. And now I'd like to turn it over to Lee Horn-Mebel, who has worked with us for 20 years, as I said, and has extensive experience in kids and adults with TS. And I think it's safe for me to say that Lee has been very impactful in the lives of many of our patients living with TSC and their families. So Lee, thank you very much for joining us.
Oh, and thank you. So good afternoon, everyone. And I'm Lee, as Dr. TL mentioned, and a clinical social worker with our center. So I'm very much looking forward to talking with you about our patients and families. I'll be talking with you today about TAND and specifically generalized anxiety disorder. You've just learned from Dr. Doyle about all the types of anxiety our patients experience, but I'll be focusing on generalized anxiety disorder because it's the most common type of anxiety we see in our patients and that I certainly treat. Dr. Doyle talked about the medications used to treat anxiety, but my focus is going to be about the other treatments and steps patients and families can take to provide much needed supports. So just as a brief recap of what we're talking about when we talk about generalized anxiety disorder, because Dr. Doyle spoke extensively on a number of different anxieties types. This type of anxiety, as we've mentioned, must last for 6 months or longer and is mainly when a person has incessant fears and worries that are frequent and they are disproportionate to what would be expected in the situations. They're about events or activities that they believe might happen or about events and activities that they know will happen, but they're very concerned and worried about them and there are many possible outcomes. So it's, you can think of it as, overthinking to the extreme. The fears and worries experienced impact daily activities, school, work, and relationships. The fears and worries that generalized anxiety disorder can take away from is experiencing the present moment and appreciating it and cause considerable difficulties with relaxing. So just to rephrase that, the fears and worries with generalized anxiety disorder sort of rob patients of being present and being in the moment because they're thinking so far ahead and they're so concerned about what's going to happen in the future. So there are many side effects to generalized anxiety. So there are many side effects that are consistent with this type of anxiety and with feeling fearful or worried. And I've mentioned a number of them here. Difficulty concentrating and focusing on tasks is understandable if worrying about things other than the present. Worrying can be extremely exhausting, as we can imagine, especially when we think that those who worry have a very difficult time relaxing. Many patients complain of feeling exhausted, but then have issues with sleep. This is usually in the form of insomnia. As a sidebar here, I'd like to say anyone experiencing sleep issues might want to consider looking up sleep hygiene. You can Google this on the internet. There you will find many ideas and suggestions along with programs to help with sleep. This is, sleep is a very hot topic right now. There's a lot of research on sleep. There's a lot of research on how it impacts other parts of our lives. And it's definitely a hot topic in neurology. There's so much research now being done on sleep. So I encourage you to look up sleep hygiene, just those two words. You'll find so much information. Moving along, so many patients complain of a heightened irritability, which over time can evolve into anger, sometimes over the most minor of things. They can experience a feeling of nervousness, which is common for patients who describe a feeling of anxiety that they experience through their whole body. I think of this as sort of a visceral response to anxiety. It's like they talk about feeling their anxiety throughout their body, almost just viscerally in their bloodstream, they sometimes say. Nervousness can make walking across a room without fear of losing balance difficult, if you think about it. For instance, patients sometimes say their anxiety causes their legs and arms to almost feel like jello. They'll say, "I feel like jello, Lee." Some patients experience a feeling of intense restlessness or unease. Sitting still can seem like an absolute impossibility. Muscle tension is common and is likely a result of difficulties relaxing. And finally, some of the side effects, physical side effects that can be associated with generalized anxiety disorder can be an increased heart rate and blood pressure, especially if there are just some more heightened, anxious moments. So anxiety for younger children is very important. Anxiety in younger children and how it impacts their childhood is very significant, and it's important for us to appreciate this because we know from extensive research that anxiety in children, if untreated, can become anxiety in adulthood. This is something we want to prevent, of course, in every way. Therefore, we want to think about what anxiety and the different facets of a child's life can look like. For starters, anxiety at school and with studies can mean easily becoming anxious with getting homework completed or worrying about understanding a homework assignment. It can include studying sufficiently for tests and feeling capable of making a good grade. I think of this as like a sense of self-agency, having a goal, working hard to make it happening, and feeling like they're capable of doing that. It can also include feeling capable of keeping up with peers and understanding all the expectations of one at school, which are just so many. One of the good things in schools resulting from the COVID pandemic has been the increase in social emotional learning. That's now provided as part of the curriculum in most schools to support students. This has helped children better identify feelings, that everyone has feelings, and understand that it's okay to ask for help dealing with them. Children can also have fears and worries about their increasing independence, which can include taking the bus to school or going for sleepovers at friends' houses. This can also include worry about the future, such as plans for summer. Sleepaway camp is sometimes a very anxiety-provoking situation for children. Expectations with summer school, or wanting to go to summer school or not, or what holiday breaks might look like, and wanting to be able to do all the things that they look forward to doing or might be anxious about doing. They can also experience anxious feelings about taking medications, staying healthy, determining whether they should go to the nurse's office, or becoming more independent with following a low glycemic diet or ketogenic diet if they utilize either of those treatments as part of their care. In terms of social situations, children want to feel a sense of acceptance by their friend groups and peers, and not feeling different because of their TS and certainly their anxiety. Those children who have epilepsy often have many fears and worries about having seizures in public, especially while at school, as you can imagine. And finally, children can have fears and worries about their family and whether their parents understand their feelings and worries and what things are like for them. And children frequently worry about relationships with their siblings. Anxious thoughts of our TS patients. Patients frequently ask about the things they feel anxious about, and this is a very, very, very short list of those most common questions I hear. So medications. Patients often talk about the taste of medications and their side effects, which is so understandable. It's common for parents to become super creative with helping their children take and tolerate medications. Dr. Doyle spoke about medications and how they can sometimes have side effects. When patients have difficulties with medications, it's understandable that they would not be too interested in yet taking another medication for something like their anxiety. But sometimes, as Dr. Doyle pointed out to us, the benefits can outweigh the costs. In terms of alternatives to these medications, because patients ask about that, this is a good time for me to mention an opportunity that's coming up at the Herscot Center with our plans to initiate a study next year exploring whether a low glycemic index diet might help reduce psychiatric symptoms of TAND and help patients avoid needing medications to treat those symptoms. We already have the MGH Pediatric Epilepsy Program Center for Dietary Therapy, where we treat epilepsy patients with this diet or the ketogenic diet. I'm looking forward to our dietitian speaking today about this upcoming research opportunity. Another worry our patients frequently express is talking with friends about TS, and especially psychiatric issues, and how to go about doing this. This is a very understandable concern and worry. It can feel very freeing to share this very personal information, but it can also cause many worries as to how to go about doing this and how it might be received. It's understandable that a patient would want those close to them to know what they're experiencing so they can be supportive. They, in turn, can feel that they aren't keeping a secret from those who are special to them. We suggest waiting to tell friends until the patient has gotten a sense of knowing them and a sense of trust that they will respect the information. This can help one feel some degree of control of their own personal story. And I can't say enough how important it is for a child to feel that they have some control of their personal information. And as I'm kind of calling it here, their personal story, their own story of their journey. Playing sports and learning to play instruments and learning other skills is so critical to development, and we want to support our patients with these interests. They are important for developing executive functioning skills, which are important to all children, such as self-discipline, organization, focusing and concentrating, developing resilience and perseverance, and they are great ways to release stress and manage anxiety, especially in sports where there's a lot of physical activity. Our rule of thumb is that if a patient has seizures, it will be important to talk to coaches or instructors about their seizure type and any special needs they might have, and specifically what to do if they have a seizure. If there are ever any safety issues related to seizures, TS, or needs around anxieties, it's always important that information be shared so people know how to provide support to your child. Sharing information with employers is usually based on a need-to-know basis. If a patient's work is in any way impacted by TS and their anxiety, especially if they have seizures, it may be helpful for their peace of mind that the employer knows their diagnosis. It's always important to think about what they might do with the information. If the patient thinks the information may not be respected, especially as relates to psychiatric issues, they may well decide not to share it. If there is a need to take time off, and we frequently get questions about this, if there's a need to take time off from work due to TAND-related issues, with the support of a medical provider, a patient or family member may qualify to utilize what's known as FMLA, the Family Medical Leave Act. This is a leave that a parent or a patient can take to support a child who is ill or needs to attend medical appointments. This would also, by the way, include therapy appointments for your child to address their anxiety. Sometimes those appointments can be weekly or bi-weekly, but a parent may need to take FMLA for those kinds of appointments. As I just mentioned, this can be used for patients who are working and need to take the time off for themselves with their jobs. Psychiatric issues, fortunately, very fortunately, can't underscore that enough, are recognized as diagnoses that may require the FMLA. So just to clarify, what I'm saying is FMLA is used for medical issues, strictly medical issues, and psychiatric issues, which of course fall under medical, but sometimes in various worlds are thought to be separate. But they are all diagnoses where FMLA can be used, and we widely support you using this. It is such an important a way to support yourself with supporting your child. And if you're working, it's a great way to support yourself with work, to take off time that's needed. I'm just, okay. So just to clarify, anxiety is not all bad. So certain, and when I say bad, I mean it's not something that we always need to jump up and do things about. And so it's important to think about what might look like as normal anxiety. And even if your child has generalized anxiety disorder, they sometimes, are having, of course, some normal anxieties that they should have. So what is normal anxiety, and why are we wanting to talk about it here? It's very important to discern normal anxiety from anxiety that requires intervention, as I just said. Everyone experiences some anxiety that is warranted with the situation. They should experience some anxiety in some situations. In fact, we might be worried if they didn't. So what exactly are we referring to? Children experience anxiety with starting school, especially like pre-K, kindergarten, first grade, progressing through the grades, the first day of school for sixth grade, the first day of school through eighth grade. They are anxious about what will be expected of them and whether they'll do a good job, make friends, know what to do. These are all just normal anxieties that, that we can work through as we experience what we're feeling some anxiety about. Getting settled in school, knowing what's expected of you can sometimes resolve some of those anxieties. Adolescents have normal anxiety about doing well in school, sports, other activities, and keeping up with their peer group. They have normal anxiety about what will happen in their future, initiate or terminating relationships, or how to deal with expectations in relationships in the workplace. Again, we would be concerned if adolescents weren't thinking about these kinds of things because they are what we call real life. So before seeking professional help, it's important to think about things parents can do to better understand what is going on for their child. The more parents get their child talking with them about their fears and worries, the better position they'll be to understand their feelings and support them. We can't work towards solving problems if we don't have some understanding of them. It's also important to stop here and think about children who are less verbal. And we have a lot of children who are much younger or with developmental reasons are still a bit less verbal. So these children are going to be expressing their feelings through their behaviors. So it will be important to work towards understanding the interpretation of those behaviors. Sometimes utilizing a board-certified behavior analyst can be tremendously helpful. You may already have someone like this involved, but if you don't, you might have heard the term BCBA. So that's what we're referring to, a board-certified behavior analyst. And they are phenomenally important with a number of our patients, especially those who have autism, with helping families and helping us understand what our patients are trying to tell us. So I can't underscore enough how important BCBAs can be. There are more things that we can do too. So there are more actions that we can take to support anxiety. Parents can maintain open communication with all of their child or adolescents providers, teachers, therapists, doctors, and encourage conversation about how their child is managing when they're with them. This is a good time to talk with them about any of your concerns, their concerns, and hear as to whether they are seeing similar things that the parents are also concerned about. And, because this is important because, children may be sharing something at home that they're not sharing at school, or they may also be sharing it at school or with coaches or other instructors or any other providers in their life. And so it's good to sort of, go and check reality of what you're hearing and seeing if others are also seeing the same things. Another idea for how parents can provide supports is to think about ways to work together as a family. Having meals a few times weekly together is a great way for parents to have their finger on the pulse of how everyone is feeling and ways for the family to talk together and support each other. This isn't going to just support an anxious child, it's going to support the whole family. I'm a huge advocate for family meetings. These can occur weekly or monthly, and it's a great way for family to bring issues to talk about together and work through. Some families even assign a person to be in charge of each meeting. This would be a great idea for school-age children and adolescents. It's a great way for families to feel connected and for an anxious child to feel supported. I can't say enough about this last idea about family meetings. I'm the biggest advocate for them. I've heard so many great stories about how families have been creative. They've even, one family recently told me that children will bring a favorite poem to read at the start of the meeting, or kids bring jokes that they've heard to talk about at the meeting, just to sort of start the meeting and break the ice. Families have just been super creative. I could go on and on. I can't say enough about family meetings. Finally, I also can't say enough about how important it is to know your child's friends, and if possible, their parents. I know the latter is not always possible, but if you can meet their parents, it's a great idea. When you know their friends, you know more about your child, your child's world, and you can understand their experience of it. And it's just another great way for you to keep your finger on the pulse, as I like to say. So when we're thinking about referring a child to a mental health clinician, so this would be for psychotherapy. And so there are licensed mental health clinicians, there are psychologists, and there are clinical social workers. We all do a lot of the same things, with the exception that psychologists are going to be able to do psychological testing. School psychologists are doing this with your child if they need an IEP or a 504. And if Dr. Teal or your neurologist has recommended neuropsych testing, you're going to see a neuropsychologist for that kind of testing, where they're going to be collecting data on how your child memories working, how they learn, how they cope, and how they understand their world. And it's a very important data. But primarily here, we're thinking about licensed mental health clinicians, we're thinking about clinical psychologists, and we're thinking about social workers. I can't say enough about, how wonderful consulting one of these can be helpful to your child. If you decide to see a therapist, these are three of the main, actually 4 of the main therapies utilized to treat generalized anxiety disorder. You've probably heard of it, cognitive behavior therapy. This is the most widely used treatment for children and adults, and it has been extremely extensively researched. CBT involves helping one learn how feelings lead to thoughts, which lead to actions and behaviors that result in consequences. This treatment is so important because it teaches one how to analyze their thoughts to prevent distorted thinking, something we call distorted thinking, and drawing false conclusions, and then acting on those false conclusions as though they're reality. Children can benefit from CBT that is geared to their developmental age and level of cognition. CBT can be fun and it can be very motivating. The amazing fact about CBT is that we all do this every day. We have feelings, we have thoughts about those feelings, and then decide on an action or behavior and have to deal with the consequences, good or bad. And CBT helps understand this in a much better way, so that children and any of us utilizing CBT can become more cognizant of how our feelings influence thoughts, influence our behaviors. And we can then change our mind about how we want to behave. it can be just one of the best things people can utilize. And it's a short treatment. It usually lasts about 12 sessions, and it can just change your world. I can't say enough about it. DBT is dialectical behavior therapy, and this is also a widely used and well-researched treatment that was developed by Marcia Linehan, a psychologist. And it's a behavior therapy focusing on helping one to learn how to regulate emotions better, cope with distress, and improve interpersonal relationships. It is often used for teens and young people because one of the good things about DBT is that it helps one understand how emotions and behaviors do not just end with them. Others can be affected by their behaviors and have feelings and take actions because of them. So it really can help, for instance, an adolescent understand that their world doesn't end at the end of their nose. When they behave in a certain way or say things in a certain way, it can affect other people who then have feelings too and react towards them. And so, you know, it's another therapy that can just really open a lot of doors for people and understanding their feelings and emotions and taking ownership of them and making changes. Acceptance and commitment therapy is actually a mindfulness-based treatment, and I'm going to talk about some mindfulness treatment shortly. That can, so ACT can help one accept thoughts and feelings without judgment and developing a plan for moving forward, especially with difficult emotions. Judgment is very good, is good for me to stop here for a moment and help us think about, because anxious people often, this is, you know, particular with generalized anxiety disorder, are very critical of themselves and judge themselves in a way that they would probably not judge anyone else. And so to be able to think about your thoughts and feelings and learn how to not judge them, but accept them as real and figure out what to do about them can be enormously helpful. And also is just one of those things that can change lives. My colleague Emma Barrows and I've talked about this so much, how ACT can really change lives. And ACT is also, just so you know, is a newer therapy. But there's a lot written about it and you might want to explore it. And lastly, something we call SPACE. SPACE is supportive parenting for anxious childhood emotions. It was developed by Dr. Eli Lebowitz at the Yale Child Study Center, just down the road from us, and has been tested and found efficacious and randomized and controlled clinical trials. Supportive parenting for anxious childhood emotions is a parent-based treatment, which I really like because it treats anxieties, but it also can treat OCD, which is something we see in our patients, and falls under TAND certainly. And it, you know, OCD is something that can be very difficult to live with and treat. So this is very helpful with that diagnosis as well. Parents participating in SPACE treatment learn skills and tools to support their child, learning coping skills that parents are actually involved with helping them learn themselves. Another great aspect of SPACE is that parents have a non-judgmental place to learn how their own behaviors might need some tweaking to do the same for their child's. This is another fun therapy to participate in because it's very motivating and it's helping parents think of strengths their child already has. So it's what we call a strengths-based treatment, and the strengths existing already in their relationship with their child and developing creative ways to build on them. So what I'm saying is identifying strengths that your child already has, and this can be so reassuring for children to have those recognized, and to find ways to build on those. This is super exciting. I can't say enough about this treatment. It's a super cool concept, in my opinion. It's very strengths-based, as I've underlined, and I hope parents of young children will explore finding providers in your area of this treatment option. And if you can't, I would love for you to get in touch with me because I want to help you with that. I love how parents can get involved in treatment themselves. You know, kids see therapists, but they don't live in a vacuum. They see a therapist maybe for generalized anxiety disorder, but they go home to families. And so it's so important for parents to be involved in their treatment, and also, you know, to feel like they're doing something hands-on that can be just so helpful. And finally, I'm including information on mindfulness exercises because they are something we highly recommend with managing generalized anxiety. And they're something that Dr. Teal herself has embraced over the last few years. Mindfulness exercises can be so significant, along with caregiver support, that sometimes seeing a therapist outside of them is not even needed. Or mindfulness exercises, along with seeing a therapist, can be so helpful that there may not be a need for medication. Super exciting there. Mindfulness exercises are practices to help one become more aware of the present moment without judgment of their thoughts. Here's judgment again, emotions, and their surroundings. Some of the many benefits of mindfulness exercises is that they can help with decreasing unwanted habits, coping with difficult thoughts, and helping with feeling calmer. I'll start with exercise, which is thought to be one of the best things to help manage anxiety. Exercise can be simple, a walk around the block, working in the yard, or it can be more formal, working out at a gym, taking a Pilates classes, working towards running a 5K. The point is to get the body moving. Patients often tell me they may be trying to solve a difficult problem and they're uncertain what to do. After walking around the neighborhood for 20 minutes, they return with several options of how to fix that problem. Meditation is a mindfulness exercise to encourage self-awareness. It's a technique to train the mind to focus on thoughts and redirect them, especially towards breathing, and focusing on connecting the mind with the body. Mindful breathing is an exercise involving focus on breathing and being aware of one's body. Progressive relaxation is a technique helping to reduce anxiety by tensing and relaxing the specific muscle groups. And visual imagery is a form of meditation using the imagination to create mental images of a calming and relaxing moment or environment. And finally, yoga, which I really love. It's a mindfulness exercise and technique that has become widely used to help connect the body, breath, and mind. I can't say enough about these mindful exercises. If you'd like to, some of you may want to take a picture with your camera of this page because these are just such important things to consider. And like I said, sometimes they are so constructive with helping patients to support themselves and to feel, you know, so much, feel a sense of control over themselves. And that can be so important with taking care of themselves and in the healing process, building self-confidence. I can go on, but you may want to take a picture of that. Speaking of pictures, you may, with your camera, also want to take a picture of this. This is a list of resources that I've put together with my colleague Emma Barrows. It's a number of resources that we highly recommend to our patients and families. As you can see, there are a number of them that have CBT. There's a workbook for CBT. There are resources on mindfulness, more mindfulness. That's how much I'm a fan of that. There are some books that are geared specifically towards parents and taking care of yourself. You know, it's very difficult and challenging sometimes to manage when children have medical needs and psychiatric needs, and it's important to take care of yourself. So I've got some resources for that purpose. And I can't say enough too about parents taking care of themselves. You know, I was recently on a flight and I was reminded when they gave the overhead, you know, safety spiel that they do at the start of the flight. And they say, parents who are traveling with children, first put the mask on yourself and then put it on your child. And I was sitting there thinking, aha, you know, you can't help the child, you can't help the other person until you're taking care of yourself real quickly. So I'm just thinking of that as a sort of little chuckle there. I also have some websites I've listed that just, you know, have all kinds of supports for addressing mental health issues, and they can just be really good in terms of helping to give you ideas of how, you know, some other ways that you can come up with to supporting your child. I thank you for your time, and I'm so glad that you've joined us for this conference. Thank you so much.
Thanks, Lee. And I have to say, that was a wicked awesome presentation, and you are definitely a TAND expert after taking care and talking with people with TS and their family for 20 years. So now I'd like to turn it to Dr. Wing Zong, our dietitian, who has been with us for a few years in the Center of Dietary Therapy of Epilepsy, soon to be Center of Dietary Therapy of TAND as well. So Wing, thanks for joining us today.
Yes, thank you so much, Dr. Teal, for introducing me. And also thank you, Lee, for the wonderful presentation. I feel like I have also learned a lot from your presentation myself.
Mm-hmm.
So hi, everyone. My name is Wing. I'm the dietitian from the Herscot Center for Tuberous Sclerosis Complex. So it's my honor today to introduce you to the low glycemic index treatment, which is one type of the ketogenic dietary therapy that was used most often at our center. So first, what is the ketogenic dietary therapy? So when asked this question, you might be wondering, you might heard about the ketogenic diet maybe on the internet, or you have heard about the words, but what is it primarily used for? So most of the current research pointing to epilepsy, and it's also mostly used for epilepsy. So it's shown to be effective treatment option for individual with seizure to help them with better seizure control. It is also used to help with individual with genetic disorders that cause them have an issue with metabolizing or breaking down carbohydrates and utilizing them in their body. Last but not least, there are more and more research recently showing that the ketogenic dietary therapy could be a treatment option to help improve symptoms for individuals with the psychiatric conditions. And that's why we are talking about it in today's conference. So there are three main types of the ketogenic dietary therapy, and the first one is called the classic ketogenic diet, which is the original ketogenic diet that used to try to mimic the fasting stage, which was shown to help with seizure control. So it's very high in fat. Actually 90% of calorie comes from fat like oil or butter, and it limits the carbohydrate to a very low amount, which is about 10 grams per day. So just to give a reference, on average, Americans eat more than 200 grams of carbohydrate per day. So this limitation is limited to like about 5% of what usually people eat per day. So it's very restrictive and could be hard to follow sometimes. So the second type is called the modified Atkins diet. It's a little more liberal than the classic ketogenic diet with it doesn't limit the protein intake, where there will be like a limitation on the protein intake on the classic ketogenic diet, but it also still have very low the limits carbohydrate intake to about 10 to 20 grams per day. Last but not least is the low glycemic index treatment, which we call LGIT at our center. We use it a lot at our center, and I would say because it's really one of the most feasible, compatible with our patient's lifestyle, and it also allows the most amount of carbohydrates on this diet. So it's still a high-fat diet, just so that we keep this in mind, but it does allow for 40 to 60 grams of low glycemic index carbohydrate per day. So let's dive more into what is the low glycemic index treatment. First, what is glycemic index? So this word, this phrase might be a little new to you. So the glycemic index refers to when you're eating a food, how fast and how high the food can raise your blood sugar. So we can also see it on the graph, just like a visual kind of images. So for example, if you're eating something, some food that have a high glycemic index, you can think of desserts like a chocolate cake. You can see on the blue line that it raises your blood sugar pretty fast to a high level, and then it drops down immediately. So you can see a steep curve as in the blue line illustrated. But when you're eating things like spinach, kale, green leafy vegetables, it actually breaks down in your body much slower, and it allows the blood glucose to increase more slowly, and then it also drops down more slowly. So you can see a much more smooth curve. So that's what the low glycemic index indicate. So for the researchers who study the glycemic index, they created a ranking system to rank like how high the food can cause the blood glucose to raise. So the ranking system ranged from 0 to 100, and is divided into 3 main categories. So low glycemic index refers to the glycemic index score of less than 55, and the high glycemic index refers to a food that have the glycemic index score higher than 70. So I know it's a little harder to kind of like imagine what the glycemic index of each food looks like without knowing some examples. Because of the time limitation, I'm not going to read out every single food that I listed over here. But in general, fats like oil, butter, sour cream, and protein like poultry, fish, cheese, beef, they are all pretty low in glycemic index. So they are all considered low glycemic index foods. So the only limitation will be towards carbohydrates, like the fruits that are low in glycemic index are apples, berries, strawberry, vegetables like asparagus, broccoli, the non-starchy vegetables, and also a very small amount of bread, grain, or cereal, things like slow cooking oats or quinoa. So for the high glycemic index foods, they are actually all carbohydrates, unfortunately. So for the fruits, such as like bananas, watermelons, dry fruits or fruit juice, vegetables like starchy vegetable like potatoes, and most of the bread, grain, cereal products that you will be able to see at the grocery store. And also sweets, candy, desserts, and ice cream are also high glycemic index. With a few exclusion that if there are some currently some specialized products, and also there are some recipes that you can make at home from scratch that will be lower in glycemic index. So you can still have desserts, but it should be coming from a specific recipe or products. So this is again ideas of like what how much carbohydrates within the low glycemic index treatment, how much protein and fat, those percentage are out of the calories. So and those are all information that I have presented before. So my main purpose of this slide is just to show you all the delicious foods to make you hungry. No, just kidding. But this is trying to show you that when you think about limiting carbohydrates, some family or parents actually are concerned that, oh, does that mean that we are only going to eat salads, or is that going to be everything that we can eat on the diet? But actually, no, there are many different ways that you can cook and make recipes to make a delicious, healthy foods that you or your kids can be on the low glycemic index treatment. And that's why we are here to help. And at our center, I want to talk briefly about the process of starting the low glycemic index treatment. So it will start with the neurologist, which for us is Dr. Teal will recommend dietary therapy. And after that, schedule will be made to meet with our social worker to briefly talking about the dietary therapy and what needs to be prepared, both with regarding to resources and how to start resources to be better prepared to start the LGIT. And then you will be meeting with the dietitian like myself to introduce more about the details about LGIT and also get an idea of what are the current food that you're currently eating. Before starting the diet, we'll like to get blood work just to make sure that you are not lacking in any vitamins or minerals or have any contraindication to start a diet just for safety purposes. And then we will going to start LGIT, which is can be over 2 to 4 weeks. So it's a slow initiation, which is nice, meaning that you can start it at home outpatient instead compared to like if you're starting a ketogenic diet, you might need to be admitted to the inpatient floor to be able to monitor any potential side effects. And the follow-up will be every 3 to 6 months where we'll monitor your weight. And for kids, we'll also monitor the height just to make sure they are growing appropriately and also doing all the routine lab works to make sure you receive all the nutrients that you need. And finally, I want to give a little bit backgrounds about the exciting future study that we are going to do to explore if LGIT can improve the symptoms of TAND. So I know that we are going to talk, Erin have a great presentation after me to talk about the medication trial and called EPICON. So the LGIT and TAND trial in terms of process, it will be very similar, just instead of the medication it is used, we are trying to use the diet as one of the intervention. So I prefer not to go into all the details because of the time purposes, but try to give you some of the backgrounds to kind of share why we think the LGIT could be an option, a treatment option for TAND. So it's actually a pretty recent research of interest. So there are many developing studies that are going on showing that the ketogenic diet in combination to medications can really help symptoms of individuals with some psychiatric conditions such as Alzheimer's, anorexia nervosa, bipolar disorder, and major depressive disorders. Although there are only few studies that come out so far, but there are active research going on at different medical centers and hospitals. So maybe you will think, well, why is diet related to psychiatric condition and how could it potentially help? Well, we don't know exactly why it helped, just like we don't know why dietary therapy, ketogenic dietary therapy can help with seizure control, but there are a few proposed mechanisms. Some people think that the diet can help by improving individuals' metabolism, improving their mitochondria function. It can help with reducing the oxidative stress. And of course, it can help with seizure control. And we know there's a relationship between seizure control and symptoms of psychiatric conditions. And also, it will help with blood glucose stabilization, which LGIT will do really well at this point, this specific point. So so that's all of my talk, and here are a lot of the resources that I use, including books and journal papers, which Dr. Teal authored the first one paper that is really helpful for me to create this presentation. So if you want to learn more about it, you can feel free to check out these resources. You can take a picture. And then I will go to the next slide where here is a QR code that you can use your camera to scan. It will bring you to our MGH dietary therapy guide. It's a brochure that we created that with more details about the dietary therapy. Again, thank you so much for listening, and I really I'm grateful to be part of the Herscot Center for Tuberous Sclerosis Complex, and thank you so much.
Thank you, Wing. And this year is the 100th anniversary of the ketogenic diet and the use of epilepsy. And as Wing said, there's really exciting growing experience of the use of a ketogenic diet or low carbohydrate diet in psychiatric disorders, bipolar, schizophrenia. So we're very hopeful and excited about this trial of using LGIT and TAND. So now I know we're running a little bit late / over. I think it can pretty clear how passionate we all are about not only take care of our patients and families with TS, but about the aspects of TAND and how it impacts them. So we have one more talk about Aaron Fonseca looking at the ongoing trial of CBD in the treatment of TAND. And if any of you have to leave, we're able to stay over the time at 3 a little bit for any questions or answers. If any of you have to leave and do have questions, please put them in the chat, and we would be happy to get back to you afterwards. So go ahead, Aaron. Thank you.
My name is Erin Fonseca, and I am one of the nurse coordinators for the Herscot Center for TSC at Massachusetts General Hospital for Children. Today, I will be speaking about the EpiCom trial. What is TAND, and what is the significance of this trial? TAND stands for Tuberous Sclerosis Complex Associated Neuropsychiatric Disorders. There has been a large push in the world of TSC to focus on the mental health aspects of the disorder. This is an exciting trial for the TSC community, as it is the first medication trial specifically geared toward TAND. The study medication is a pharmaceutical-grade cannabidiol solution, which is in a sesame seed oil formulation and has a strawberry flavor. As you can see here from this image of TAND, developed by Petrus de Vries, Anna Jansen, and Stephanie Van Klooster, this is an umbrella term used to describe disorders at the behavioral, psychiatric, intellectual, academic, neuropsychological, and psychosocial level. Some of the most common behavioral aspects of TAND that we see are anxiety, depression, OCD-like behaviors, and sleep problems. And as you can see on the other levels, including anxiety disorder, ADHD, autism. Also, some TSC patients may have issues with sustained attention, cognitive flexibility, self-esteem, and relationship difficulties. The study is designed to be add-on therapy for TSC patients who have a history or current epilepsy, who are on at least one anti-epileptic drug that is stable with regard to dose for 4 weeks leading up to screening. This is an open label study, which means that each patient in the study will be getting the study medication. This study can be done completely virtual if needed, or in person based on preference. At week 52, study participants will undergo a final assessment. The study participant may be eligible to receive reimbursement for some study-related expenses, such as hotel and travel. The study will take place in the US and Canada, as well as the UK and Poland. The goal of the study is to evaluate the changes in behavioral and neuropsychiatric symptoms of TAND. The study will be assessing behaviors, mood, seizures, and sleep. The study is designed to be 62 weeks long in 4 different periods. The screening period, the baseline period that lasts 4 weeks and includes completing multiple screening and baseline assessments, and the treatment period is broken up into a few different phases, including the titration, the maintenance, and then the review. When patients opt to continue taking the investigational medication, or they may stop the drug. In investigational drug studies, there are inclusion and exclusion criteria to determine if the study is right for the participant and if the participant is right for the study. In order to be eligible for the study in the US, the participant must be between the ages of 1 and 65 years old, and internationally must be between 2 and 65 years old. The participant must have tuberous sclerosis complex, a history of or current epilepsy, and must be on at least 1 anti-epileptic drug. The participant, even those with normal cognition, must have a caregiver throughout the study that will answer questionnaires and be able to rate the severity of their TAND behaviors. For exclusion criteria, or not being eligible for the study, would include those individuals who are pregnant and breastfeeding, anyone who has started felbamate within 12 months of screening, anyone taking an investigational drug within 3 months of screening, is currently taking CBD or recreational cannabis within 3 months of screening, has a history of alcohol and or substance abuse, and those who may have impaired liver function. Lab testing will be a regular part of the study visits. For a more comprehensive list of inclusion and exclusion criteria, please see the EpiCom study website at epicomstudy.com. This here is a simplified version of the study schedule. Time is a very valuable resource, and I know with the busy lives that TSC families live, the study schedule may be a deciding factor in your ability to participate in a clinical trial. The baseline visit may happen together with the screening visit, or the baseline visit may be up to 4 weeks apart from the screening visit. During these visits, we go over the consent, speak about medical history, speak about current medications and history of medications, and then we discuss inclusion and exclusion criteria. The baseline visit is similar, discussing any changes to the medical history, current medications. And then, as you can see below, in treatment period 1, at visit 3, you would receive the investigational drug. The visits following are following up on how the patient is doing, how the participant is doing in the trial. If they have any questions, they reach out to the study nurse or the PI. Thank you so much for listening to my presentation on the EpiCom study. For any questions or interest in enrolling in the EpiCom study, please reach out to me at efonseca1@mgb.org.
Thank you very much, Erin. And that concludes kind of the content for our meeting today. And again, I know we've run over a few minutes. Jan, I think there is at least one question in the chat. I think we probably have time if people can stay on to chat about.
So hi again, everyone. I hope you all enjoyed the presentations. We just have a couple of questions in the chat. There's a good question, I think, which is pertained to a number of our patients regarding episodes of, excuse me, hyperventilation. Any input on why a child would hyperventilate and breath hold multiple times a day only during periods of wakefulness? Phenotype does not show as seizures on over 100 plus video EEGs. So I guess that'd be a question for you, Dr. Teal, or
Sure. I think that that is not at all uncommon, especially if children have autism. Hyperventilating like that can be a kind of self-stim behavior. If a child doesn't have autism, sometimes that can be a manifestation of anxiety. We have one of our kids now, we're trying to figure out kind of what is the hyperventilation, is it seizure, is it not? So I think very common in children with autism to have either we met a child the other day who doesn't have TS but is autistic, who has kind of attracted to the light and runs in and out of shadows and light because it gives him kind of a euphoric feeling behavior. But can be very difficult, especially if children are nonverbal and can't explain to you why they're hyperventilating. But it's important to know and good to know that on EEG, these episodes have not shown up as seizure. And important to do an EEG in that setting. With children with TS or any child with autism, if they have kind of what looks like a paroxysmal, very stereotype behavior, and we're not sure, is this some kind of self-stimulatory behavior, is it seizure, et cetera, then the EEG can be very, very helpful in determining is it seizure or is it not.
okay, and our second, actually, and last question, I think was addressed somewhat during Dr. Doyle's talk. But the question is, what have you found in terms of using Wellbutrin for TSC patients? It's an attractive option, but I know it can significantly affect seizure threshold. From the material in this presentation, it sounds like it's not a major concern, but I'd still be interested to hear more about how you would approach this. So I don't know if Dr. Doyle is still on or...
It looks like he is on, but he has left, so he probably had to go see one of the 70 patients he has to round on today on our Saturday. I think that, like he said, you know, kind of when we approach management of seizures and behaviors in TS, it's a balance between controlling the seizures and also optimizing therapy for the different behavioral manifestations. So we have plenty of patients who have been on Wellbutrin, and we go into it saying kind of, we know that this is a possible side effect of Wellbutrin and just monitor. And in general, I don't think we've had a significant problem with it, and it can be a very effective medication. So I would probably work with and make sure that the neurologists and the psychiatrists are communicating and knowing, and that's again, the beauty of the Herscot Center and other programs like this is we all talk to each other on a very frequent basis, and we talk about medication changes and combinations, knowing that one change might impact other things. But Wellbutrin can be very effective.
And then one more question. This will be for Wing. Quick diet question. Are keto diet and low glycemic index diet compatible with renal diet?
Yeah, thank you so much for the question. I think it depends on what kind of like renal concern or conditions that individual can have. And usually if someone have like renal issues, then we'll be more concerned about the protein intake. And because for like a higher protein diet, it might not be necessarily very helpful for the kidney. So we usually work very closely with nephrology, with the patient's nephrologist, just to make sure that everything that we put together is compatible and support optimal kidney health as well. So it really depends on the individual in this perspective.
Thanks, Wing. And then the last comment in the chat is Cindy, and Cindy, I get it. That's one of our missions at the MGH is to take care of not only children but also adults with TS. And TAND issues are just as significant for adults living with TS as for children. Maybe sometimes more impactful in overall quality of life and ability to function. And so please get in touch with us if there's any way that we could help or be of assistance. But again, I would like to thank you all for taking a couple of hours out of your Saturday to join us. These are wicked important issues in TSC. And as I said earlier, I'm really incredibly excited that this has become an increasing focus of not only clinical care and interest and focus in TSC, but also research. And again, I'd like to really thank the people here from my group. It's a lot in addition to our busy work schedules to organize and put on programs like this. And I'm wicked proud of the people I work with. So thank you.